Good morning. So I want to talk a little bit about our ERAS protocol and how we can build artificial intelligence into it. So objectives to introduce our perioperative surgical home model, our ERAS protocols that has contributed to a decreased length of stay, some of our current research in AI, and our future directions. So Periop Surgical Home promotes the adoption of ERAS protocols to promote the progression of care. The goal is to really use a multimodal and multidisciplinary strategy to facilitate the recovery process and also improve patient experience and reduce length of stay. We don't just look at when the patient comes in for surgery and the period afterwards. We actually start to capturing the patients before they even come in, when they hit the clinic. How can we risk stratify them to improve the process? So a little bit about our service. We started in 2015, and as part of this test of change, we wanted to implement multiple ERAS protocols, try to facilitate patient recovery, and try to really get a very coordinated care plan for the patients through surgery. And this project actually launched in 2018 after undergoing over 100 meetings. So part of our ERAS protocol, we have our pre-op anesthetic clinic. So basically, most of the patients that come through surgery, they will go through the pre-anesthetic clinic. There, either an anesthesiologist or their primary care doctor will look at the patient to see, are the patients ready for surgery? Is there anything, any kind of studies that needs to be done? Do they need to be further optimized? For the patients with very high MEDD, they will go to Dr. Carl Whitnable's clinic and to determine how can we cut the opioids and optimize them before surgery. Every day there is a daily spine pilot list that gets sent out to all the providers, but also everybody on the care team that takes care of the patient. So we expect who's coming and we know who they are. For the very high risk patients, if we've had issues with them in the past, if they have very high MEDD, we'll actually get an email over a week ahead of time so we know, okay, what should we expect for the patient? What do we need to have in place before they even come in? Best practice alert for ERAS protocol for the anesthesiologists that are taking care of these spine patients. Once you open the chart, there will be a pop-up and it will tell them what the MEDDs for these patients are. And for the very high MEDDs, those will automatically go to the pain service afterwards. And there will be actually a chart with the recommended pain medication regimen that would be suggested for intra-op use. Periop service, so there's a group of 5 of us. We basically act as the surgical primary for the patient. We're available 24/7, 7 days a week, and we are on service 7 days at a time. So this way, there is some continuity of care, and we take care of the patients on the floor, and we communicate with all of the staff and also our surgical team when they're operating and they may not be available to answer questions. And another thing is the progression of care rounds. This is something kind of unique to Cedars. Basically, we have a very fragmented care system here. Each of us kind of take a piece of the patient, we fix that problem, but really there's really no one point person that kind of looks at the patient as a whole and kind of takes the driver position. For example, if you have a patient who is a couple days post-op, the physician may see the patient in the morning and say, okay, they may be ready for discharge this afternoon. They put in their note. The nurse may not have read the note. They have 4 different patients to juggle. There's a miscommunication, and now it's 4 p.m. We're asking, how come the patient is still here if they haven't gone home? Scripts haven't been filled. The home health hasn't been set up. And patients saying, well, it's 4 o'clock. There's a lot of traffic. Why don't you just send me home tomorrow? Now we just added another day into their hospital stay. So the progression of care rounds happen every day in the morning. It consists of different players in the patient's care. So a little bit about each member's roles. So the nurse that's taking care of the patient, they see the patient pretty much the most out of everybody. So they know exactly what is happening to the patient. Are they walking? Are they eating? How are they progressing? The case manager and social worker, they help us coordinate what kind of insurance do they have. Are they eligible for post-op physical therapy for home health? We have a rehab facility that we work very closely with. They understand what kind of patients we have and how their recovery process is going to look at. And they're able to tell us and evaluate the patient and say, hey, we think this would be a good candidate to come to our facility. A lot of our physicians that are a part of Cedars, primary care doctors, specialists also go to this facility so they can follow the patient through their care. Our pharmacist is able to look at the drugs they're on to make sure there's no interactions. Any patients that needs long-term antibiotics, they'll make sure a PICC line is set up ahead of time and coordinate some kind of home health infusion. So this way, everybody's on the same page on a daily basis to anticipate this patient's progression. And what's really important about this process is that it's led by a physician. There is a physician advocate, and also the Periop attending is at this meeting every single day. So every day we are looking at the patient to see, okay, is this ready? Is this patient ready to go? What's the barrier to care so we can get them out of the hospital and get them home faster. So some of our outcomes, from 2015 to 2018, we have been able to decrease our length of stay by more than a day. And comparing nationwide, we started above national average, and now we are significantly below. And in the last couple years, we have been able to sustain that. So let's change gears and talk a little bit about artificial intelligence. We live in an age of big data. We collect a lot of data through electronic medical health records, but what do we do with it? It's a very cumbersome process to sort through all this data and to spend a lot of money to make use of it. But the data is out there, and we're progressing towards a very cost-effective a quality care, right? We want to increase the quality, decrease cost, value-based care. So can artificial intelligence help us in that process? So what is the buzz with artificial intelligence? Traditionally we use statistical models to analyze patient data. This is a study that was done in Europe from 2003 into 2009. They looked at comparing and using an artificial model compared to our statistical model, which one can give us a better prediction for length of stay. In the study, all of the patients were enrolled in a ERAS protocol, and the AI model was able to predict length of stay at a much higher and more accurate rate compared to a statistical model. And it was also able to show that the patients who are more adherent to the ERAS protocol had better length of stay and better 30-day readmission rates. In Cleveland Clinic, they're currently using AI to help them with the decision-making for patients coming with low back pain. So, there's a very wide range of, opinions and treatment plans when a patient comes in with back pain. Oftentimes, patients will come to the clinic multiple times. Some people will take them to surgery right away. Others will say, maybe let's try conservative treatment. So there's a lot of time that's wasted. And with the AI model, it's able to, come up with a decision and a treatment plan much faster and also improve patient access to care. So currently at Cedars, we're trying out our AI model, Alex. We have so far over 3,500 patients part of our spine project. So we feed all of the data of these patients, and we also feed into the model their actual length of stay. And the model is able to give us a predicted length of stay. It uses an algorithm that is already built in. And what's so powerful about this is that it's not one algorithm that is used. Every time a new data point is fed into this model, it will learn from it. For example, it's flu season. So anybody who has a fever, who has a flu, the model is able to see, okay, that's going to prolong the length of stay. And it's also going to trial all these different types of algorithm to see which one is going to give the better prediction. So the model is constantly learning and constantly changing. So far, we've identified 109 different variables that we are feeding into it. And comparing the length of stay, the actual length of stay and what is predicted, we're about a day and a quarter within vicinity. And the goal is to bring that down to below 1. It's also been able to identify some of the more important variables. As you can see here, time in surgery, pre-op length of stay, and inpatient DRG were the most heavily weighted factors that helped us determine the length of stay. This is just an example for the actual versus post-op length of stay. The orange bar is the predicted, and the little blue dots are the actual patient data. As you can see, there's more variability between 120 minutes to 270 minutes. And this is kind of the areas that's been able to identify, and we're looking through our data to see why is there so much variation. Same here with the different types of surgeries, like with the cervical fusion with the anterior approach, and also the lumbar fusion with the anterior approach. There's more variability, maybe because with these kind of surgeries, patients have more swallowing difficulties versus post-op ileus, but we're able to identify these risk factors. So our next step is to improve our predictability to less than a day. We're using AI model to help us risk stratify patients. So once this model, we have more data, we can build it into our EPIC system. So when a patient comes into the clinic, we can say, okay, this patient will probably have a length of stay of so many days. Are there any factors that we can, that's actionable, that we can change to help reduce their length of stay, and also predict, give the hospital kind of a predictive cost analysis for that patient. Also, we want to increase the model transparency, so we know, okay, if a patient has a post-op, length of stay of predicted of 4 days, exactly which variables are contributing to that. And a big thanks to everybody that's been involved. We're very excited for the next step.